A 74-year-old female who is a known case of diabetes, hypertension, dyslipidemia, COPD, presented with the complaints of excessive daytime sleepiness since 1 year, which was gradually worsened to the extent now she is not able to do her day-to-day activities.
What are the reasons for excessive sleepiness in the daytime?
Sir, one may be due to because of
One is mainly due to laziness. Mainly laziness. Second thing.
OS.
Since you are a pulmonologist, you are telling OSA. That is okay. Then narcolepsy. Okay. Then
CLD patient in
Hepatic
okay. Hepatic encephalopathy. Then common things you tell. That is a common thing. Hypothyroidism, hypoadrenalism. Okay, all these things, but the most important reason, like you told, OSA will be the one of the commonest thing where you get daytime sleepiness, early morning excess sleep, headache, all these things.
And she also complains of excessive snoring, which was witnessed by her spouse, and complaints of multiple episodes of sudden cessation of breathing during sleep. And she also complains of sleep disturbance and early morning headaches. No complaints of chest pain, orthopnea, and PND. Past history, she had underwent a total TKR for bilateral OANE. Personal history, there is decreased history of sleep, normal bowel and bladder habits. Family history, history of obesity in her father. On examination, she is obese, oriented, of weight of 90 kgs, height of 156, BMI of 37.
How do you calculate BMI?
Sir, weight in kg by height in meters.
Okay.
Then
next. The BMI in this patient?
37.
Okay, that is
very obese.
Very obese.
Neck circumference of 50, sir. There was a bilateral pitting pedal edema was there.
What is the importance of neck circumference in this type of patients?
For excessive fat.
Excessive fat deposit in the neck, short neck, thick neck, all features of OSA.
Yes, sir.
Especially short neck persons.
Only mouth opening, there was only visualization of part of uvula was seen.
Okay. What is the importance of this emergency doctor?
Intubation, difficult intubation.
Yes. Then vitals of heart rate of 90, blood pressure of 150/90, saturation of 90 in room.
Heart rate is?
90.
Okay.
Then routine BP is 150/90.
115. What will happen to BP in OS?
Hypertension.
Hypertension.
There will be overnight non-dipping pattern.
Okay.
Then routine investigations were done. CBC total count of 9,000 and hemoglobin of 15.2. Cardiac enzymes were negative.
Hematocrit value?
Hematocrit.
Is it important?
Yeah, important.
Why?
Sir, polycythemia.
Secondary polycythemia. Hypoxia-induced secondary polycythemia. Okay. Most of these patients will have some polycythemia. Here it is 15. So if you have a very high hematocrit value more than 50, then you have to suspect to have polycythemia.
HbA1c of 7.1, sir. Then echo 7.1. We calculated stop bank score for her, sir. That is snoring, tiredness. Have anyone observed for a sudden cessation of breathing? Then B for BMI, BMI of more than 30, sir. Then neck circumference of more than 40. Gender, males are more common, sir. Then age of more than 50. If it is score of 0 to 2, it is low risk. 3 to 4, it is moderate. More than 5 is high risk. For her, it is 6. High risk for OSA. Then we have done echo. Echo, it was EF of 60. Concentric LVH were there. Then mild PAH was there. Good LV, no regional motion abnormality. Then we did sleep study for her, overnight sleep studies. Well, apnea hypopnea index was around 31.5. Usually less than 5 is normal, sir. 5 to 15 is mild. 15 to 30 is moderate. More than 30 is severe OSA. So she had severe OSA. And
sleep study.
Sleep study. And similarly, her.
What is the scientific name for sleep study?
Polysomnography. Then her lowest oxygen desaturation noted in sleep study was 58. Sir.
Okay.
Then respiratory index was around 32.6. That is also indicative of severe OSA. Then we started her on a CPAP titration study. CPAP titration study is that we will fit CPAP mask overnight and we'll measure the pressures. At what pressure, that eliminates all breathing difficulties in all stages of sleep. That is recorded. For her, it came as 10 centimeter of pressure. So we have initiated her on CPAP at 10 centimeter of pressure. Now she's maintaining with that. So basically,
what is the basic difference between CPAP and IPAP?
Sir,
You already told.
continuous.
Okay, so continuously you are giving a pressure to prevent the collapse of the airway. Okay. Other one is?
Inspiratory.
Okay, so where all you use BiPAP, where all you use CPAP?
We plan to wash out the carbon
CO2 washout.
We will do by
Bilateral. In case of
pulmonary edema is one of the conditions where we use CPAP here in emergency room. Okay, initially, then you can use it as a BiPAP. Okay, but OSA it is a continuous CPAP only.
So to tell it as an OSA, either she should have a nocturnal disturbances like snoring, gasping, and excessive daytime sleepiness, which could not be explained by other medical problems, or else in sleep study, more than 5 episodes of AHI or apnea or hypopnea per hour of sleep. So basic mechanism is during inspiration there will be negative intraluminal pressure that will cause the pharyngeal dilator muscle to collapse. But during wakefulness, because of our neuromuscular input, the pharyngeal dilator muscle will keep the airway open. But during sleep, that tone will be reduced, so airway will get collapsed.
Okay.
So because
in a patient who is on ventilator, obstructive sleep apnea, when you are extubating, what precaution you take?
You have to extubate
Yes, told.
CPAP.
You have to extubate to CPAP, otherwise what will happen?
again collapse.
Airway collapse and again you will have to intubate the patient. Re-intubation may be required. So it is always better to extubate the patient to a CPAP. Then you try to see what is happening. Otherwise immediately you will have to re-intubate the patient.
So, sir, because of that hypoxia and hypercapnia, physiological ventilatory drive will stimulate our diaphragm and pharyngeal muscles, sleep arousal, so sleep fragmentation, so intermittent hypoxia. So, basic risk factors, most common site of collapse will be soft palate.
Okay.
Other areas will be our epiglottis, lateral pharyngeal wall, or base of tongue. So then risk factors like small airway, large tongue, bulky uvula, then
short airway. Yeah,
short
you
airway.
mean short airway,
Short
not
airway.
long.
Short airways.
Short airway.
Then any craniofacial abnormality, retrognathia, micrognathia. Then obesity. Then male
Where
gender.
you get micrognathia?
Sir,
Macrognathia?
micro. The Treacher Collins and congenital syndromes, and then Down syndrome also. Then male gender are more prone because of android obesity. The fat will get deposited in the neck and abdomen. And postmenopausal women. Then endocrine abnormality, hypothyroid and acromegaly. Then so basic approaches we should ask the sleeping history, so snoring, gasping. Dyspnea will be a less common issue.
Choking sensation is common symptom told by the patient. Snoring is a common symptom told by the spouse.
Then excessive daytime sleepiness, insomnia, then early morning headaches, dryness, irritability and mood changes will be there. Then
even they get sleep while riding the bike or car. So that is also possible. So they meet with accidents.
Then physical findings, there will be hypertension will be there, non-dipping pattern will be there. Then obesity, we should look for any nasal deviation, DNS or any polyp or anything that also will cause collapse. Then oropharynx examination, large tongue, that uvula size, high arched palate and also. Then cardiac examination to rule out.
High arched palate is a risk factor for OSA.
Some high arched.
High arched is actually good. I don't know. High arched palate is actually good for the patient. High arched palate is you get in which condition? Okay, that may be the reason for it. But that is in children.
I will confirm.
That is in children, not in adult. Normally, high arched palate is a feature of what type of personality? Marfan's. But that they don't develop OSA, no? But this adenoid can produce.
Adenoid
right?
hypertrophy and
Otherwise, I don't know.
tonsillar hypertrophy.
Okay.
Then neuromuscular examination to look out any neurological disorders. Then common
Which cranial nerve involvement?
hypo.
9 and 10.
Then sleep study will do either whole night sleep studies or limited channel sleep study.
Okay.
In full channel sleep study, there will be 12 parameters will be recorded, or EEG, EOG, then electromyogram, and ECG and heart rate, then respiratory effort, airflow, then patient's position during sleep, then oxygen saturation, snoring by means of microphone. Whereas in limited channel, we'll record only 4 to 7 channels, like airflow and respiratory effort, saturation, and sometime body position will be seen. Full limited channel we can use if we are it is a confirmed OSA, whether to support the diagnosis we can go it, or else we will go for full channel sleep study.
What is the role of PFT in these patients? Will you do a PFT for all patients?
Yes. So,
What is the role?
to look for
Coexisting?
OS, OAD.
Obstructive airway disease.
disease.
Okay.
Then the parameters reported in sleep study will be AHI, apnea hypopnea index will be seen. Then respiratory index. Apnea is cessation of breathing for less than 10 seconds. Hypopnea is less than 30% reduction in airflow.
Okay.
Then respiratory distribution index will be seen. That is both apnea, hypopnea plus respiratory effort related in arousal. All these 3 parameters will come under RDA. Then oxygen saturation index will be seen. Then apart from that, we can see sleep latency, sleep efficiency, arousal index, and sleep stage distribution, and periodic limb movements can be seen. So management. Basic management is lifestyle modifications, weight reduction, then regular sleep setting of regular sleep cycle, then avoiding.
What is it, regular sleep cycle? What tablets will help?
Melatonin.
What you told is a brand name. Melatonin.
Then to increase physical activity. So best treatment will come with CPAP. Then other things
is there
like
any other local devices?
oral appliances that will move the jaw forward,
Okay.
that can be applied.
Tongue fall, it can
Tongue
prevent
fall,
tongue
yeah.
fall. There are devices to prevent tongue fall, but the best approach, like you told, it is CPAP only.
Yes. Then we can go for hypoglossal nerve stimulation, that one
Okay.
is there. Then positional therapy, some alarms will be set to prevent patient from sleeping from the back.
Okay.
In addition to that, we can go for surgery if it is severe OSA.
Okay. But nowadays, surgery is not a choice. It is only CPAP.
Yes. Then as I told, CPAP titration study will be done in 3 parts. So either one full night will be spent for CPAP, or split CPAP titration. First half will do polysomnography, second half will do CPAP titration study.
Okay.
Nowadays automated CPAP has come that will adjust pressure according to the breathing difficulties.
Okay.
That can be initiated at home, that they don't want to spend at labs for titration. Then the Epworth sleepiness score is there, sir, to classify the quantification of daytime sleepiness. That score 0 to 10 will be normal, more than 10 will be excessive, whereas more than 16 is high level of daytime sleepiness will be there.
Or want to add something? We are getting lot of cases now, obstructive sleep apnea. Most of the time, it is unnoticed. Unless until we do a sleep study, we will not get. But clinically, it will be very relevant when you get a patient who is having type 2 respiratory failure with compensation, obese individual coming to emergency room or ICU. You have to always overdiagnose. Sometimes we have to do overdiagnosis. OSA may be part of your diagnosis. We may miss it. And we may sometimes diagnose it as COPD, where the patient will not have any COPD at all. The type 2 respiratory failure is due to OSA. Obese individuals, hypothyroid. We get many patients who is unconscious, come with low GCS. Maybe the reason is OSA. Anything else? You're all working in emergency room. This will be most of the time it will be missed. Okay. And finally brand him as COPD. And we'll be giving lot of nebulization, all these things. They are all unwanted things. That's why PFT should be done in all these patients to rule out associated OATs. Okay. ENT evaluation is required.
Yes, sir.
That is also required. DNS, adenoids, or
Adenoids,
polyps, all
polyps.
these things we should rule out. Okay. Okay, thank you.